Hi everyone, this will be video lecture number 3 for the Palliative series, and we're going to talk about pain management today. So just to go over a couple of objectives for this lecture that I'm going to record here, so we want to understand different types of pain management techniques and the importance of patient education to improve patient quality of life. We also want to understand the different types of pain medications, side effects, typical dosing and uses. And then third, understand how to recognize a patient with drug dependence, tolerance, and or addiction. So when you're seeing a patient and you are responsible for managing their pain, there's a couple of things that you will need to think about. One, each pain management plan should be individualized, meaning that even if patients have the same diagnosis, it's not their specific management plan will be different. People have different types of pain. People rate their pain differently, so they feel pain differently. It affects their lives differently. So all these plans should be individualized for that patient. The second thing is it should be measurable. So it's really important when I talk to patients, especially if I'm doing an intake exam and they're just starting with our palliative care service, it's really important for me to ask them, how is this pain affecting your life? So if they're telling me that it's very important for them to be able to stand and brush their teeth, but because of their pain they're not able to do that, that's something that as you develop a pain management plan and you're trying different options, that's something that you can measure and that you can see an improvement or maybe not an improvement in. So if you start them on a medication and you want to reevaluate in a month to see, are they able, is their pain more managed, you can say, are you able to stand and brush your teeth now? And they can say yes or no, or maybe yes, I can stand for a couple of minutes and then I have to take a break. And that's an improvement. So that's something that you can measure. The other thing is you want to include short-term goals and long-term goals. So it's important to also make sure that these are realistic. So some people say, I just don't want to have any pain at all. And that is an opportunity to give some patient teaching, because a lot of the times, because these chronic diseases, we're not necessarily fixing the disease, but we are managing the symptoms of it. A lot of the times we're not going to be able to get them to a 0 on their pain scale. So let's start with some small goals. Let's say, okay, your pain level right now you're rating it at an 8. Let's get it down to a 5, because that seems to be a little bit more manageable to you according to what they say. Long-term goal, we want I want you to be able to do some of these activities with your family that you haven't been able to do because your pain has been at a level 8. So those can be more long-term goals. Pain management plan should also include both pharmacologic and non-pharmacologic interventions. So for some people, maybe it would be helpful to add in a monthly massage. And some palliative care programs are actually able to provide this for their patients. Other ones have contacts that they can give patients that they could go to get a little bit of a discount on this. But these are things that you would be able to include in that plan. These next few slides, I want to talk about some of the more common family of drugs that we use to help with people's pain. So what I'll do is we will talk generally about a family of medications, and then I'm going to go over some of the more common medications from that group. And we'll go over, some of the dosing a little bit, but I will tell you, palliative care is very much, it's based on creativity, because sometimes you are using these medications maybe even in higher doses than what you would typically see on Hippocrates or something like that. However, there is evidence-based practice behind doing that for a palliative care patient. So just keep that in mind. This pain management is very different from someone that maybe just has chronic pain from a car accident or something like that, and they're seeing an actual pain management physician or a provider. So this palliative care pain management is at times very different from that type of pain management. So the first family that we're going to talk about is the corticosteroids, and these are very common. You'll see a lot of these. So some of the more common ones are the Decadron, the prednisone. Those are probably the two most common that you'll see. The most commonly used one in hospice care is Decadron, and that's because it tends to be a little bit more potent. But we do use it in palliative care patients. I actually really liked Decadron with my cancer patients. And the corticosteroids are best used for neuropathic pain and visceral pain. So when you're trying to develop a plan for someone, keep in mind that these are great for those types of pain. Okay, so the first one we're going to talk about is that Decadron, and I know we said just a couple things about it a moment ago, but dexamethasone, it causes less fluid retention than some of the other steroids, and specifically that's prednisone. So, you know, long-term steroid use, you have to be careful in people that have any sort of cardiac disease, and the reason for that is it can instigate almost like a congestive heart failure type syndrome. Decadron is less known, or I'm sorry, not less known, it's less likely to cause that. So that's one reason why we tend to like Decadron a lot. The typical dosing of Decadron is about 2 to 8 milligrams, and that's by mouth, and it can be 1 to 3 times daily. Now, the thing is you don't want to just start somebody on a high dose of this. Usually we will titrate slowly up because it's one of those things that people can get used to a certain dose, especially if you have them on a high dose, they can get used to that and then it won't be helpful for them anymore. Also, too, is it still can cause some fluid retention. Specifically, it's usually more bilateral lower extremity edema. So we do have to just be a little bit careful. Not starting them on high doses. We need to make sure they tolerate it okay. Some other things that it can do is it can also cause some GI upset. So it's important for people to take it with food. And then again, those lower doses are less likely to do that. So that's why we start lower. So we already talked a little bit about some of the side effects, but some serious reactions again is that CHF. They can get some peptic ulcers, which is why it's important for them to eat with this. Long-term use, they can develop some osteoporosis. The other thing is on the high doses, if you are going to be weaning, or well, if you're going to be taking somebody off of a high dose of this, you need to wean them off because they can have withdrawal symptoms. Some common reactions that you'll see is that nausea, vomiting, so again, those GI symptoms. Sometimes people will develop a headache with it, and they usually complain of these headaches back on their in the occipital area. People also, which I'm sure you have seen this if you're working in the hospital, will have some hyperglycemia. So keep that in mind. If you have a diabetic patient that you're starting this on, you just need to be careful with that. You might have to go up on their insulin or their medications. And again, it can cause that edema. Typically, it's in the bilateral lower extremities. And this usually, if it's going to happen, so if a person is going to respond to Decadron like that, it's usually that edema is going to happen within the first 2 weeks. So you might need to follow with them a little bit more closely. Next, we're going to talk about some non-opioid analgesics, so the aminophenol derivatives. An example of that would be Tylenol. This is best used for that somatic type pain. If you haven't had a chance to listen to the lecture 1 and 2 that I made, make sure you look at that, or make sure you listen to that so that you understand the different types of pains. Also, there's aspirin. That's also best used for somatic pain. And then the NSAIDs. So we have ibuprofen, the ketorolac, naproxen, Celebrex. All of these are used for somatic visceral type pain. Although we do have to be a little careful with these as well, and we'll go over that. Okay, so let's talk about Mobic or meloxicam. You guys probably see this a lot. A lot of the pain management physicians like using Mobic as well. So this will be seen not just with palliative care patients. So a black box warning to be just to be familiar with is that patients that have a history of heart disease, they can have an increased risk of blood clot with long-term use of Mobic. So just keep that in mind. You also have to be cautious in prescribing this for a patient that has a history of a GI bleed. If it was a pretty decent GI bleed and they had to go in and actually have a surgical repair to correct the GI bleed, I probably would not prescribe an NSAID to them. However, if for other reasons you're limited in your pain management options, then you have to look at risk versus benefit. So typical dosing for Mobic is 7.5 milligrams to 15 milligrams, and that's given daily. Now, if the creatinine clearance is less than 15, then typically you avoid use altogether. So some serious side effects, again, we talked about GI bleed. They're more likely to have an MI, so a myocardial infarction or congestive heart failure type syndrome, nephrotoxicity. They are more likely to have DVTs from this, GI ulcers, anemia. So all of those are really, basically, it's important to follow these patients. This is one of those medications that you see so commonly in people, and it actually causes a lot more problems than what people think. So some common reactions are your GI symptoms. They can also develop some fluid retention, so just make note of that. Next, let's talk about Indocin. Again, that black box warning, it's pretty much the same for all of the NSAIDs. We want to be careful if people have a history of heart disease. It does increase their risk of a blood clot. We have to be cautious in people that have a history of GI bleed. So typical dosing is about 25 milligrams by mouth, and that is, you can do it in a BID dosing or a TID dosing. However, the max of that is 200 milligrams in a 24-hour period. They also have an extended release form of it, and typically we prescribe 75 milligrams daily, and the max for that is up to 150 milligrams. But I will tell you, those higher doses, there's really not any more research showing that those are more effective than some of those, like the lower dose, like the 75 milligrams or 100 milligrams. So keep that in mind. You don't necessarily always need to go up on that. We might need to look at, do we have the appropriate medication for their pain? So serious side effects, it kind of is similar to Mobic. So GI bleeding, stroke, MI, CHF. You have to watch the kidneys. Common reaction, again, is that GI type symptoms, peripheral fluid retention. People can get really constipated with this one. So I didn't always use this one a whole lot, but when I did, I always prescribed a stool softener with it. So keep that in mind. Okay, so let's talk about opioids, which is more of the common medications that people think of when they hear hospice and palliative care. And what I'm talking about is the morphine, the oxycodone, the methadone, fentanyl. Those are probably the more commonly used ones. A lot of the times I didn't really like tramadol, so I did not use tramadol a whole lot in my palliative care patients, especially if they're older, because it put them at more of a risk for a fall. These are more commonly used for somatic, visceral, and neuropathic pain. Now, not all of them are used for those, and we'll go over that, because like methadone is really better for neuropathic type pain, whereas morphine is better for somatic and visceral. So we'll go over those. These are considered Schedule II drugs, and they do require a written prescription and close follow-up with documentation of need. So you have to make sure that you are very specific in your documentation of why this is appropriate and why it's needed. So I always would document what we have tried and didn't work, so that if I did ever get audited, people would see that we did try other things first, like non-opioid type medications. So we tried those first and they were not successful. So now we're having to escalate into this opioid family. Okay, so let's talk about morphine here. There's lots of different names that morphine can have. All the drug companies want to get their brand out there, basically. Morphine's been around for a long time. So it does come in long acting, and it also comes in short acting. And I put some of those names there that way, you may or may not have heard them. Cadian is really used more so outpatient. I don't think I've ever seen that inpatient. If you're working in inpatient currently, you probably see a lot of Roxanol. But like MS Contin is more of an outpatient drug too. You might see a person come into the hospital with that, but more commonly that's used outpatient. Black box warning, and I'm sure you guys probably know this from pharmacology, but you want to encourage patients to avoid alcohol use because it can cause oversedation. And there is a higher risk of abuse and addiction with these medications, and it can also cause a higher risk of respiratory depression. So it's important to make sure that we understand that when we're prescribing these medications. So some of the typical dosing, so Avenza, 30 milligrams every 24 hours. It tends to be more of a long acting, but you can go up to 1,600 milligrams per day with that one. MS Contin, I will tell you, is literally the most cheapest form for patients to use. So I used a lot of MS Contin. Cadian still tends to be a little expensive, and Avenza does as well. So MS Cotton I used a lot. It also comes in an extended release form. You can do that 15 milligrams extended release every 8 to 12 hours. Max is about 200 milligrams a day. Well, and then let me talk about Roxanol here first, and then I'll tell you something about morphine. But so Roxanol, we do about 10 to 30 milligrams by mouth every 3 to 4 hours. Or you can do 10 to 20 milligrams rectally every 4 hours. Now, there are different orders, especially for people that maybe are closer towards that hospice, but not specifically hospice yet. We can even do Q1 hour until a pain relief level is reached. So this is my soapbox about morphine, because a lot of providers will just go and prescribe morphine because it's easy to prescribe. People feel comfortable prescribing morphine. However, you cannot prescribe morphine for a patient that does not have working kidneys. So definitely people that are on dialysis, they cannot have morphine because it builds up in their system and it causes a drug-induced metabolic encephalopathy. And it really can cause a lot of problems for the patient and even cause their death very quickly. So if you do go into pain management or you go into palliative care, please make sure that you look at the creatinine clearance, because if the creatinine clearance is less than 15, then we need to start looking at like a Dilaudid or a fentanyl. These people just really, they just cannot, they cannot use morphine correctly. So it builds up inappropriately. So keep that in mind. Okay, so finishing about morphine, I couldn't fit it all on the other slide. So some side effects, and I know you guys probably know this, but serious ones are respiratory depression, apnea, hypotension, bradycardia. Common reactions, people will develop a headache, and that's actually pretty common. People will also develop some diaphoresis. Constipation is a huge one with morphine. So, and actually with all the opioids. So any opioid I prescribe, I always prescribe at least a stool softener, if not something like a Miralax that would be a little bit more potent than just a Colace. People will develop a facial flushing. Sometimes they can develop edema and urinary retention too. So just things to keep in mind. Okay, so next we're going to talk about oxycodone, and I actually really like oxycodone. People usually found pretty good relief with oxycodone, especially if you're using it for people that have pain due to some cardiac diseases, or people that have pain from like bone cancers, things like that. Oxycodone actually works really well. So typical dosing of this is 5 milligrams every 6 hours by mouth. You can do a max of 160 milligrams per day. There's also an extended release, although I will tell you the extended release right now is still pretty expensive. So a lot of people will do just the regular oxycodone. But the extended release, we do 10 milligrams. You can do that every 24 hours, and the max is 160 per day as well. Side effects for this one, some serious, it's similar to morphine. So respiratory depression, oxycodone is more likely to cause an increase in ICP. So that you have to be really careful for people that have brain tumors or, a history of stroke, especially brainstem strokes. It can also cause hypotension or apnea. And then some common reaction is, again, that constipation. So again, we prescribe something for that with the opioid. They can also cause some GI symptoms as well. You also have to be careful if people already are not eating and they're losing weight, and that is harming them and harming their quality of life, then we probably need to look at something else, because it can cause more symptoms like anorexia than it will than the morphine or like Dilaudid. Okay, so let's talk about fentanyl. I actually really like fentanyl, and I felt like when my patients were on fentanyl, they had pretty good pain relief. So more commonly in the outpatient world, we'll use the fentanyl patch. Again, that black box warning, we have to be careful for respiratory depression. Typical dosing, we would start at the 12.5 mics patch, and that is, it's put on and kept on for about 72 hours. We can decrease that down to every 48 hours, but typically, or more commonly, you're going to see every 3 days or 72 hours. Max is 150. Now, research shows that people don't necessarily have better pain relief with the higher doses. The higher doses can sometimes just overwhelm a person's system. So sometimes if you are noticing that a person, you went up on the fentanyl to try to relieve their pain, and really now their pain is even worse, I would encourage you to back down and then possibly look at maybe switching their medications, because that happens a lot of the times with fentanyl. Some side effects, again, serious reactions is that respiratory depression, hypotension, bradycardia. Common reaction, again, is that those GI symptoms. It can also cause some anxiety, so keep that in mind. I've seen that a lot in the dementia patients. If we give them a fentanyl patch, the higher the dose, the more anxiety they have and the more confusion they have. So keep that in mind if you do use these in the more confused patients. You also have to be very careful using fentanyl patches, because I've had patients that, they're diagnosed with a terminal cancer, not necessarily hospice appropriate, but they're having a lot of pain. And so we would try a fentanyl patch with them. Well, these people have history of drug abuse, and because of the stress and, just all the uncertainty, being diagnosed with a terminal cancer, now it's causing that addiction to come back. So I have seen people try to suck the medication out of these fentanyl patches and things like that, and they can actually really harm themselves. So just keep that in mind. You really have to know your patient, because this is a medication that is very commonly, if I can think of the word that I want to use, it's very common for people to abuse it, basically. Next, we're going to talk about methadone, and methadone is actually one of my favorite medications to use. There are a lot of things when you talk about documentation that needs to be in place before you prescribe methadone. A lot of people will just start them on methadone, and they don't have any of these boxes checked when they are talking about documentation. So one of the things we need to make sure is that we need to get an EKG before starting methadone, because we need to know what that QT looks like. Methadone is notorious for messing with that QT, and so for people that have a QT over 380, 400, you really should probably consider not prescribing methadone for them, because more than likely they're going to that QT is going to be lengthened and they're going to have problems, and you can actually cause sudden cardiac death. So I always make sure, especially because if I ever got audited, I always make sure that when I'm prescribing methadone, I get an EKG. I check all of their electrolytes. So I typically will get a CMP, and then you can add a magnesium level to that CMP. And I monitor those. So I see these patients monthly, but when I'm first starting them on methadone, I would actually see them in 3 days. So I would see them in 3 days after starting methadone. Then I would see them in 2 weeks. And then after that, then I would start seeing them monthly. And it's just to be cautious, because this is, it can be a harsh medication for some people. So it can also cause respiratory depression, like morphine and fentanyl. Typical dosing. So people that are on methadone because of drug addiction, you're going to see them on these crazy doses. And actually research has shown that those doses that are that high actually are not helpful to a person's pain. So the lower doses of methadone actually do a much better job of making sure a patient's pain is under control. So typically we start them on 2.5 milligrams, and we'll give that to them every 8 to 12 hours. Now the max dose for pain control purposes is 20 milligrams every 8 hours. Okay. Side effects, again, respiratory depression. They can have hypotension, definitely hypotension with methadone. So somebody that already has low blood pressures, we need to make sure that we watch that. Death is in there because of the QT. And then, of course, arrhythmias, bradycardia, cardiomyopathy. Some common reactions, one that I see very often with methadone, especially within the first 2 weeks of using it, because really it takes 2 weeks for a person to get used to this medication, is the dizziness. So if you have a person that's complaining of dizziness, we probably need to educate on fall prevention. We might need to see if we need to go down in their dose a little bit, or maybe not as frequent dosing. But a lot of the times if they get past the first 2 weeks, that dizziness goes away. It can also cause those GI symptoms. It can definitely cause some constipation, so we have to watch that. Okay, so this slide and then the next slide, I want to talk about some common opioid combos that you'll see. I know you guys have probably seen Norco a lot, and that's hydrocodone and acetaminophen. Blackbox warning, it's associated with liver toxicity with high doses, and that's because of the acetaminophen. So we want to be really careful. We do not prescribe this in people that have any sort of liver cancer. I really am careful even with GI, just any GI cancer. So just keep that in mind. Typical dosing is 2.5 milligrams to 10 milligrams every 4 to 6 hours. This is one that people commonly abuse, so you have to be very careful. These people have to be seen at least every 4 weeks, if not more. And anybody who I was prescribing pain medication, even if they were 80 years old, we still, because of our policy, we drug screened them every 4 weeks. And so you have to make sure that you know the drug screening policy for wherever you work if you're prescribing pain medication. Side effects, respiratory depression, again, that liver toxicity, dependency. Some common side effects you'll see is that dizziness. A lot of people will complain of nausea, vomiting, and again, constipation. Next one is Percocet, and I know you guys have probably seen this too. Again, it's that liver toxicity that we have to be very careful with high doses. Typical dosing for this one is 2.5 to 10 milligrams. We can give that every 4 to 6 hours. Typically, you'll see it every 6. Serious side effects is hypotension, respiratory depression, again, that liver toxicity. You can also see seizures with the oxycodone, and then renal failure. Common side effects is that dizziness, the sedation, and the GI symptoms. Percocet can also, so if you see down there common side effects, euphoria. Sometimes people, they'll just be very euphoric. I've also had patients that have told me that it causes them to have nightmares. So just keep that in mind. If somebody all of a sudden is complaining that they're not sleeping well and they're just having these nightmares, it could actually be the Percocet too. Moving on to muscle relaxants. So we're talking about Baclofen, Flexeril, Robaxin, Soma, Xanaflex. These are really best used for somatic and visceral type pains. And they're actually pretty common. We use them a lot in palliative care. So you may, if you take care of palliative care patients, you may see them a lot. So let's talk about Flexeril. I tend to actually really like Flexeril. I think people tolerate it pretty well. Typical dosing is 10 milligrams. You can give that up to 3 times daily. You don't want to have a person taking more than 60 milligrams a day. You do want to be careful if people have a history of any cardiac disease, because it can cause arrhythmias, it can cause an MI, it can cause a stroke. Common side effects, especially within the first 2 weeks, people will complain that they just feel kind of drowsy. After the first 2 weeks and they've been on the medication, if they're taking it scheduled, a lot of people will say this improves. It can also cause a headache. It causes some taste changes as well. Sometimes people will just complain that things just don't taste like they remember. Sometimes they'll taste more sour, or sometimes things will be too sweet. It just changes their taste buds. And then also it causes some constipation. So keep that in mind. If you have a person that's on an opioid, then you're also having them on a muscle relaxant. You have them on 2 medications that can cause constipation. So, pain management, I am always asking about, are they having bowel movements appropriately? Because all these medications we put them on will cause constipation. Next is Baclofen. It's typically in literature, this is more of your first line drug, although sometimes the Flexeril tends to be a little bit less expensive for people, which is why I tended to like it. I also, with Baclofen, I tended to see more drowsiness and dizziness. So that's why I usually would go more towards the Flexeril, but you can do Baclofen, and that'll be fine. Of course, you have to monitor your patient like you normally would. So 5 milligrams up to TID. Max is you can give them 20 milligrams QID actually if they're really having a lot of pain. Serious side effects is that CNS depression, syncope, hallucinations is another one with Baclofen, which is why I was very careful. I don't think I ever prescribed the max, the 20 milligrams QID, because a lot of people will develop those hallucinations way before that. So just keep that in mind when you're prescribing this medication. And then common, again, drowsiness, dizziness, weakness, some GI symptoms, some confusion, and then some impaired coordination. So these people should not be driving if they're taking this medication. Okay, so now we're going to talk about some medications that you may not have thought about for pain management, but they actually do a really great job. So the tricyclic antidepressants, some examples would be Elavil, Pamelor. They're best used for neuropathic pain, and like I said, they actually do a fantastic job with a lot of people's neuropathic pain. So people that have that diabetic neuropathy, or people that have like neurofibromatosis, or maybe they have cancer that has involved or has some nerve involvement. These actually do a pretty decent job helping with that type of pain. Okay, so we'll talk about Pamelor first. So Blackbox Warning that you have to be concerned about is that sometimes this medication can increase suicidal thoughts in some patients. So if you have a patient that has a history of attempted suicide, or maybe they have a history of some depression, keep that in mind. You're going to really want to watch them closely, especially the first 2 to 4 weeks that you start this medication. So typical dosing is about 25 milligrams. You can give that by mouth daily. The max is 150 milligrams. Side note, you can also give this rectally too. You can actually have, so compounding pharmacies, they can actually make this so that you are able to administer it rectally. Compounding pharmacies are the best friend of palliative care providers, because they literally can make you anything out of any medication. Now, of course, it changes the absorption rate and things like that, so you have to keep that in mind, but they are extremely helpful. When I worked in Findlay, we had a great compound pharmacy that was right down from our clinic, and I seriously probably talked to them probably over 10 times every day, because they were just so helpful, and they were great with our patients too. So side effects of this medication, it can definitely cause some orthostatic hypotension. I have seen that in multiple people before, so keep that in mind if you have a person that, says every time they stand up or move positions, they're just so dizzy and it's making them nauseous, and, we probably need to check their blood pressure. It also can mess with that QT, hallucinations, depression, SIADH. I've seen that once in one patient. She was a cancer patient. Just keep that in mind. These things can happen. The common symptoms that you'll see, though, is weakness, drowsiness, palpitations, tachycardia. You'll see some appetite increase, which can be a good thing as well, too, and then urinary frequency. Okay, so now we'll talk about the SNRIs. Some examples of this are Effexor, Cymbalta. Most common you'll see is the Cymbalta that's used for neuropathic pain. And I can't tell you, my goodness, I prescribe Cymbalta for a lot of neuropathic pain for people. And this was probably one of my more favorites to use, because it just did so great. And people, for the most part, tolerated it pretty good. Okay, so talking about Cymbalta here. So Blackbox Warning, again, it can increase those suicidal thoughts. Typical dosing of Cymbalta is about 30 milligrams daily. You can give up to 120 milligrams daily, but I will tell you, especially at Ohio Health, we work with Epic. If you go over 60 milligrams per day of the Cymbalta, it's going to red flag you and, say, are you sure, you want to prescribe more than 60? With palliative care, like I said in the beginning, we tend to use some different, less common doses that, people maybe are not as familiar with or as comfortable with. But yes, you can go up 120 milligrams per day. Side effects, though, similar to the Pamelor, the big thing that this one can cause, though, is it can cause some mania type symptoms. So you have to be careful in people that have a comorbid bipolar disorder. You just want to keep that in mind, especially if they tend to be more manic. It can actually exacerbate that. Common, you'll see those GI symptoms. With this one, you'll see actually the appetite can decrease. So keep that in mind if you have somebody that you really need to have, they really need to gain some weight. I actually would usually use Cymbalta and then Marinol, which is like it's a synthetic type marijuana, but it's one that we can prescribe, and it's made in a pill form. I would actually prescribe the two together, and it would take care of a lot of symptoms together. So the Marinol takes care of the appetite and a lot of the times the nausea, and the Cymbalta would take care of the neuropathic pain and not being able to sleep at night. So together, those two actually worked really well, and that was one of my more common combinations that I liked. Next, we'll talk about anticonvulsants. These aren't as common, I would say, except for the gabapentin. The gabapentin we use a lot, but, I really didn't see a whole lot of the anticonvulsants used, and the one that I typically prescribed was the gabapentin. So, again, like I said, the gabapentin is the more common one, and then they're best used for neuropathic pain. So the gabapentin or the Neurontin, typical dosing is about 300 milligrams by mouth TID. The max that you really don't want to go over is the 3,600 milligrams per day. I will tell you, gabapentin is one of those, you wouldn't think it, but you really have to monitor your patients closely because more people have been found to be abusing gabapentin. Which is unfortunate because it really is a great medication and does a lot of good for our patients. So I followed with these people closely, even though it's not an opioid and you wouldn't necessarily think gabapentin would be one you'd want to abuse. It does, and family members will actually take this from patients and abuse it as well. So I'm always very careful about that. Some serious side effects are depression. They can also get hostile. Acute renal failure is probably one of the biggest ones. So a person that has a lower creatinine clearance, I would not suggest using this medication. I would try to use more of a Cymbalta or something like that to help with their neuropathic pain. People can also have angioedema with this one. They're just very sensitive to it. So keep that in mind too. If that's going to happen, that's going to happen with the first to 3 doses. You're going to see that. With withdrawal as well, this is something, if you have them on higher doses, you don't just stop this medication. You are going to titrate them off of it because they can have seizures. So common, you'll see people have dizziness. They might have this ataxia. Peripheral edema can actually be common as well, and that's usually in the legs. And then they can also develop a tremor. We're going to talk about sodium channel blockers. Example is the probably more common one that you've heard of is the lidocaine. And this is best used for peripheral neuropathic pain, and we'll go over that. Okay, so we're going to talk about the lidoderm patch, which I'm sure a lot of you have seen or heard about. A lot of pain management docs like to use the lidoderm patches too, although they are extremely expensive. So if you have a patient that's complaining of multiple areas where they're hurting and they're going to need 3 or 4 patches, then you're going to have to be careful with that because it's going to be very expensive for them. Typical dosing is 5% patch on for 12 hours and off for 12 hours. The max they say is 3 patches at a time, although a person that doesn't have any sort of cardiac history or any sort of neuro history, you can go up to 4. I usually would limit myself to 3. It can cause some CNS depression, that cardiac arrest, seizure. More common though, you'll see site reactions. People just won't tolerate that well, and it'll cause like a burning or an itching. If that's the case, then that would be, it would be probably just an indication that we need to try something else. Now, I know we talked about all the pharmacologic measures, but just remember there's a lot of non-pharmacologic measures that you can do as well too. And there's actually a lot of really good research, especially in palliative care and hospice patients, that these type of interventions help. So, and this is, we're talking about music therapy, pet therapy, chiropractic care, relaxation techniques, so like deep breathing or yoga, hypnosis, acupuncture, massage, exercise. Exercise is actually fantastic for people that are depressed or people that have poor sleep habits. As long as they can exercise, it really is a great intervention to do for people. Especially my cancer patients, my younger cancer patients, I would always encourage them to exercise. And it doesn't have to necessarily be running. People always think of running or going to the gym, but anything that kind of gets your heart rate up a little bit and causes those endorphins to release, that exercise is perfect, and it'll be helpful to them. Okay, so now briefly we're going to talk about drug abuse. And there's substance use disorder, there's physical dependence, there's drug addiction, and drug tolerance. So what is substance use disorder? So it's a term that encompasses both dependence on and abuse of alcohol and or drugs. And this can include non-medical use of prescription drugs taken voluntarily for the purpose of their effect. And it's this effect on the central nervous system that, people crave. And they take it, after a while, after they've been taking them, then they want to take more of them because they want to prevent the withdrawal symptoms then. So the prevalence of this in the United States has been reported 22 million, and not all of them are reported, so it probably is higher than that. And there's a higher incidence of this disorder in those with any sort of mental health illness. So keep that in mind, because you will see a lot of patients that come to you with a mental health illness. Usually this behavior at times is a result of inadequate pain management. So if you see a patient and they are drug seeking, before you make that assumption that it's an inappropriate drug seeking, let's see, is it because their pain isn't controlled? Is it because their disease is progressing, that they're not getting pain relief anymore from the pain management plan that we had created maybe 6 months ago? Really, every time I saw a patient, I reevaluated if their pain management plan was appropriate, and that's something that all of us should be doing. Physical dependence. So drug dependence means that a person needs that drug to function normally, or to keep some of those physical withdrawal effects away, or they like the physical effects that the drug causes to occur. So an example would be, and this doesn't have to necessarily be illegal drugs or pain medication. An example of this would even be certain blood pressure medications do not cause addiction, but they do cause a physical dependence because our body needs them in order to maintain a blood pressure at a certain level. Drug tolerance is one that you will see a lot with people that are in palliative care and hospice, and so it's a state in which a person no longer responds to a drug. And usually a higher dose of a drug is required for the same desired effect, or I would say maybe we need to switch them to a different drug. And so that's why sometimes you have to be really creative when you are prescribing pain medications for a patient, because after a while that pain medication may just not work. The body just got used to it, and we need to either go up in the dose, or sometimes we even need to go down in the dose if the lower doses work better, or we just need to talk about switching to a different drug altogether. So the development of tolerance is not necessarily addiction, it's just that the drugs produce tolerance within the body. So drug addiction is when there is a dependence, and typically it's on an illegal drug or a medication that's not being used for its right purpose. So when a patient is addicted, they may not be able to control their drug use, and they may continue using the drug despite the harm it causes. So they mentally think that they need this drug in order to function appropriately. I included this picture just for a visualization, but it's just important to understand that addiction and that dependence and where that occurs at in the brain. Okay, so just for this slide and the next one here, we'll cycle back to that pain management. So patient education. I cannot stress enough that whenever you are creating a pain management plan for a patient, whether they be a palliative care patient or a hospice patient, it is extremely important that you provide patient education, and it needs to be thorough. And it needs to be not just to the patient, but it needs to be to the family, especially because they need to understand that the same pain management plan today may not be their pain management plan in 6 months from now, because they have a chronic disease, and we will expect that that disease will progress at some point. We also need to teach patients and families to report changes in pain, pain that is new or pain that doesn't improve after the intervention that you've provided them. We also need to discuss the concept of pain with the patient and their family. So what does pain mean to that patient, and what does it mean to their family? What's important to them? What gives them quality of life? What takes away quality from their life when they're in pain? So these are all discussions to be had with them. We also want to discuss medication use, and this is one that nurses are a lot of the times very familiar with, because we do this all the time with our patients. But we talk about what is the dosage, what's the medication, how to administer it, what are some side effects we need to watch for. So these are all things that, again, still need to be included, even though we're going to be, you guys are going to be in that NP role. And then some patients may underreport pain due just to various reasons. It could be culture, it could be because they don't want to appear weak. You want to explain the reasons with patients and help them understand the importance of proper pain control, and how, them being honest with you will help you get them better pain control. So sometimes you just have to have a little heart-to-heart with them. Okay, so lastly, this is the ABCDE pain assessment and management tool, and I actually use this a lot. I think it's very helpful with pain management. So I included it on this last slide here just because I wanted you guys to be able to have this and see it. Of course, there's other, pain assessment and management models out there, but this one just happens to kind of be my favorite. So A, you want to ask about pain regularly. You want to assess pain systematically. B, you want to believe the patient and the family and their reports of pain and what relieves it. C, you want to choose pain control options that are appropriate for the patient, family, and the setting. And D, you want to deliver interventions in a timely, logical, and coordinated fashion. And then lastly, E, you want to empower patients and their family. You want to enable them to control their course to the greatest extent possible. And a lot of the times we can do that through patient education and that patient-provider relationship development. If you guys have any questions, send me emails. Thanks, guys.